Good evening. Good evening. Well, hello. My name is Stephen Collins. I'm the CEO of Matter. And first of all, thank you for coming out. I haven't been outside in a little while, but I keep seeing these alerts that we have the first ever ice storm in a decade here. So I wasn't sure whether you were actually going to come, given the situation. So thank you very much for braving whatever it is an ice storm actually is to be here with us. I think it's going to be a really interesting program. So for those of you who haven't spent a lot of time at Matter, I'll just give you a quick rundown of kind of where we are. So we are almost exactly 4 years old. We do three things. We're a startup incubator, we are a nexus for the healthcare community, and we're a corporate innovation accelerator. Our 200 startup companies that we work with last year raised about $260 million to fuel their growth. They generated about $100 million collectively, and their solutions have benefited about 90 million people. So we're very proud of the progress that our companies are making. We are a corporate innovation accelerator. We have about 70 partners. Our partners are leaders in healthcare, and we work with them to understand their business challenges, what their innovation needs are, and how we can harness entrepreneurial energy to help them solve their challenges and their innovation needs. And then we bring the healthcare community together for really interesting discussions like the one that you're going to see tonight. So we have Rowan Chapman here from California. Again, apologies for the weather today, and thank you for coming here from California to do this, even though there's an ice storm. Rowan leads J&J Innovation. Her title is J&J Innovation California. She actually has a much more expansive role than that. She's part of the J&J Innovation leadership team and has responsibilities both in the United States and outside the US. And I am sure that she will explain J&J Innovation, because there are a number of pieces to it, of which many of you are no doubt familiar with some of those different pieces. She has really an interesting background. So she was at GE Ventures leading their healthcare investments. Prior to that, she ran the precision diagnostics business at GE Healthcare, and then she spent more than a decade as a partner at Moore David Dow Ventures, one of the top venture firms in Silicon Valley, and had some startup experience before that after she had her PhD. So lots of interesting things that I know she's going to share with us this evening. She will be interviewed by Tom Kowalik, who leads the life sciences practice for Accenture in the Midwest. And Accenture has been a terrific partner of ours since we opened. They really helped us flesh out a number of the ideas and a number of the programs that we have implemented in the very early stages of Matter, and they've continued to be a terrific partners of ours since we launched this place. Tom is part of their global life sciences leadership. They have about 15,000 consultants working in the life sciences realm, and so we're really happy that Tom is both on our advisory board and a part of our community, and that he's here tonight to lead this discussion with Rowan. For those of you online or those of you in the room, we're using social QA for questions. So if you go to matter.socialqa.com, you can ask a question, and Tom will have the iPad to moderate those questions. So with that, please welcome Tom and Rowan.
Need that trusty iPad. All right.
Can't live without your digital tools.
That's right. We planned. Rowan has picked blue. I have selected chartreuse, so we hope the colors work for you. And with that, we are off. So I'll be monitoring some of your questions throughout. I'm going to start with a few that I've thought up and seeded a little bit here, because she's got a really, really unique perspective and history. And through that, so many different vantage points on this topic of the evolution of data. So I'm just going to start there. And maybe you could just take us on a little bit of a history lesson through kind of those various vantage points that Stephen mentioned. And what has the evolution of data in the health space been since you've been working through it?
Oh, wow, that is a big question. You're not breaking me in gently here, are you? So I'm not going to reveal my exact age, but I came to the US many, many years ago to do a postdoc at UCSF. And at that point in time, I don't think any genome had been sequenced. Okay, just a perspective. And I had been used to pouring gels. Does anybody remember sequencing gels and loading them by hand and mixing up those little tubes and counting the bars and all of that kind of thing? So let's just take that from that vantage point to then what happens now, and we can sequence the whole human genome for, I think it's a couple of $100 these days, at least if you're using Illumina. Is that the whole genome? We'll get to that. Is that the whole genome? But if you think about that evolution, that is a tremendous thing in the last 25 years. Tremendous evolution of data, and has completely changed the way we think about utilization of population-level data to enable drugs that work for an individual person. So that's just one perspective. And let's take the next vantage point. So when I went into startups, the first startup I went to was a company called Insight. And there was a race to sequence the human genome by that point. And there was the question of how many genes are there in the human genome? And what's an EST? And what's a variant of a gene? And we think about it now. You just go on a database and look. And it's free and it's available. But at that point in time, there are all these people trying to understand what is the human genome.
Right.
Still don't think we know the answer. But I think we've got a guess of what an average is at this point. But that was that part of the evolution. And at that point, that's where, for me personally, I suddenly realized that we were going to have lots more data from all different types of data, but we didn't know how to analyze the data. And the people who knew how to analyze the data, or the people who were smartest about it, were the astrophysicists in the world, because they were the only guys that really had a lot of data to analyze. So at that point, I went, I am going to go and join that group of astrophysicists. So the next startup I went to was a company called Rosetta. So I went and joined a pile of physicists at 10-person company, went and joined them, did business development, became this translator between what's the biological problem and what can you do technologically. And this is where those things called microarrays, which people don't tend to use quite so much anymore, but those ones were being developed by Affymetrix and by Rosetta actually as well, and by Agilent. Remember those days?
I do.
And the question
Not
was...
to date myself.
Not to date yourself. But the question, so it was, how much data can you get? And then that got into what's the quality control of the data, and how do you use advanced statistics to analyze the kind of data. And at that point in time, it's like, wow, this is so much data. But a very smart man called Eric Schadt said to me, Rowan, we've got all the algorithms for analyzing the data. We're going to get lots and lots of data, but we don't have the compute infrastructure for allowing those algorithms to work. So just kind of keep that in mind. That's like the late 90s. And then I went off, and after we did an IPO and got acquired by Merck, side kind of comment here, I said at that point, I will never work for a large company. And I worked for a couple of the largest now. I will never work for a large company. And I managed to leave Merck the day they acquired Rosetta. So I went off into venture capital and I joined a tech firm because I was obsessed by this idea of what's the infrastructure, what's the technological infrastructure to enable those algorithms for the data that's going to come. And then I didn't predict what we're doing with cell phones these days, but that's the last 10 years, and suddenly all of the different data sources are happening and they're getting significantly less expensive. While I was at Moore Davidow, a young man came to talk to me, and he had been one of the first CIO of Facebook, and he said, Rowan, teach me about biology, because he saw the same thing. Great conversation. That man then went off and founded Cloudera. Cloudera, cloud computing, enabling, you see the connection to the algorithms, because we had these conversations. Then later, he actually went off and did a PhD in genetics and became a professor at Mount Sinai. So So I think we're seeing this kind of emergence and convergence, which is the stuff that I get super excited about as long as we're solving real human healthcare problems. So 11 years in venture capital, massively increasing amounts of data, decreasing costs. And then there was this moment, and it was in 2012. And I was a board member on a whole series of startups, across the spectrum. And I've got lots of great stories, successes and failures. And I went downstairs to my husband, same husband through the whole of this
Congratulations.
Journey. Same husband through the whole of this
Same
journey.
wife through the same thing.
So. But the point being is I told him I will never work for a large company. I went down to him and said, I'm going to go and work for a large company. And he said to me, you will not survive, you are crazy. I said, why? He said, because you're the wrong person for a large company. I said, no, I need to go to a large company because I'm sitting on all these venture boards. And the people who come from the large companies have a very different perspective than the people who come from the small companies. I've just spent 15 years in small companies. And I've never been accused of being the calm person in the room. I want to get a bit of that calm. I want a little bit of that perspective. I want to be able to say, this is how the customers are thinking about it. So I said, I'm going to go work for a large company, and that's how I ended up at GE. And then I think everything's just speeding up. Maybe it's just getting old. I'm just getting old, but everything is speeding up. And we're seeing the emergence of digital therapeutics. I'm still amazed, but then you think about it, and it makes sense. We're seeing digital therapeutics. We're seeing data-enabled clinical studies. Hey, clinical studies were always data-enabled, but I'm talking big data-enabled clinical studies. We're seeing miniaturization and cost reduction in everything in terms of, think about DNA encoded libraries and screening. That's changing the way people are thinking about drug discovery. And so now I'm at J&J, largest healthcare company in the world, and we are looking constantly for new innovation, and this world of data meets biology is just colliding across our different sectors.
Oh, exciting.
Hope that helps.
How's that for a different set of perspectives on data? Yeah, right? Okay, well, I think we should clap for that one. That's a career, right? Yeah, I mean, that's a beautiful thing and so many vantage points. And I love how you started to layer in kind of the economics with the evolution of the data. So the economics, the cost coming down for sequencing, for the, to actually produce or acquire or even capture data, to store data, compute power going up. But the various uses that you kind of touched on there, the proliferation of where we're creating value with data across the health ecosystem. So here we are in 2019. That was a lovely trip through history and really interesting. In today's environment, sitting at J&J today, but as a perspective from the industry, where do you see the greatest opportunity?
That is such a tough question. I'm not going to answer. That's a bit like saying which of my kids is my favorite. Mm-hmm. I don't have a favorite. They're all beautiful in their own way.
No.
So in the role that I do at J&J, mm-hmm. I'm responsible for the western half of North America and some other, and Australia. And we are, the team that I lead, we're responsible for making sure that we access the right innovation across the different sectors of J&J. That's a big job because the sectors include Janssen Pharmaceuticals with its 6 different therapeutic areas, includes the medical device business with surgery and surgery tools, cutters, sealers, you name it, digital robotics. We have the consumer business. Think about digital beauty, think about skincare, think about oral care, think about baby care. And we have to make sure that we're seeing innovation across those spectrum. And the data-enabled opportunities are different depending on which part of the business that we're looking at. For example, in consumer, it might be something associated with digital beauty and the vast amount of data that can be available from a scan of the skin. But then you think about that same technology from scanning the skin from a beauty perspective, and that's really relevant, shall we say, for psoriasis on the pharmaceutical side. Same technology is connecting the dots to a completely different business model in a different part of the business. So if I look on the pharmaceutical side, some of the things I talked about, DNA-encoded libraries, I think the data that comes from them and the iteration that you can do early in drug development, to me, is tremendously exciting. But then when we think about impact on patients, that's going to impact patients because I believe we're going to get better therapeutics via that. But then you think about immediate impact on patients of, let's say, a digital app that actually changes the way you are taking a medication or the way you're thinking, the way your brain is working. Tremendous impact on patients using those digital technologies. So that's why I can't pick a favorite, because I can get excited.
I think that's a fair from the roundtable earlier today. I think we would probably all agree.
What are you most excited about?
What am I most excited? She told me that as the questions get a little bit dicier, she's going to come back at me. So this is all fair play. I'm excited about the seams. I'm excited about consumerism in healthcare. Everybody being driven to a patient perspective. I'm excited about the collaboration that's coming and the people who are looking at data that doesn't originate from within healthcare, that they're thinking about how it applies to improving patients' lives out in the consumer sector, in electronics, in high tech, in retail. So that's what jazzes me. So I think there's a lot there. We'll come back to that in a minute.
I've got some more questions for you on that.
Yeah. So well, I guess let's think about, because that's a bit of a loaded answer, I guess, because it presumes something, which is the nature of who's competing and how we're competing in the healthcare space is changing, right? So I would argue that it was a pretty simple model when you started out, right? We used a lot of data to discover and develop drugs, and we informed that, and then we knew very little about patients and out there, and only what we learned through some very kind of naive trial, and then it was brought into the market, and then we just started learning again. We didn't know how to reach them and how to, today it's a really complex environment, right? And one of the things that is happening with data is we've kind of got the sandwich, right? At one end, we've got all this regulation. We've got HIPAA, we've got GDPR, we've got all of these forces that are trying to govern and control. And at the same time, and by example, we do a survey every year around patient services. And the patients that we surveyed here in the US and in the UK, 64% of them said, I will gladly give you my data if you can help improve my health outcomes. Mm-hmm. What do you make of that sandwich?
What do I make of that sandwich? I think you have to take it up to the level of what products are going to improve healthcare outcomes. If you work with that goal in mind, what's a meaningful difference to the patient? And you always target that, then you ask the questions. So the first question you say, does that patient want to release their data and why? And then can we make sure that patient is protected if they release that data? So I think that's all consistent with better health outcomes. On the other side, the regulations are there to protect us as individuals and to make sure that the right proof points are done and to make sure that drugs are safe, interventions are safe, and the right claims are made, because none of us are able to say, oh, I think that product works or that product doesn't work without clinical evidence. So if you then look at that and say, is it going to make a difference to the patient? Yes, if you have the data. Now let's connect those two things together. Where does the data for those clinical studies that are going to give you definitive evidence or directional evidence come from? It comes from the patient. All clinical studies are done in patients. And patient consent for clinical studies has been going on for decades because somebody doesn't go and do a clinical study without giving their consent. Mm-hmm. The thing that's changed is that we have cell phones and we also have genetic data sitting out there. So with the cell phones, that's changed the way we do clinical studies, and this is the emergence of real-world evidence. What we have to make sure is that the regulations protect that patient's data, but that the regulatory authorities are willing to use that kind of data as an alternative phenotype or endpoint. That's happening, that's going on, and there's multiple companies working with communities of patients to make sure that the N, the statistic, is greater. We need better statistics in clinical studies, and that's what's happening with the increased data. On the other side, on the genetic side, we end up with databases of populations of people with their genome sequenced, connected to their phenotype and their outcomes. Again, you have to be really careful about permissioning on that, because what you don't want to do is to reveal to somebody who doesn't want to know that they actually have a variant that is going to lead to something which is incurable or there's nothing you can do about it. So again, you have to protect the patient, and my personal belief is that you need to re-verify every time in both cases. Patient, despite your genetics sitting in this database, or patient, despite the fact that you're streaming from your cell phone to some provider, do you want your data to be used for this particular question? And I think the patient, in the end, has to make that decision. That's my personal belief. And I think in cases where there's something you can do something about the data on the genetic side, most patients would actually want to know. I mean, I'm going to share an example. I don't think I told you this in a pre-call. Personal example.
Okay.
Okay. So.
Okay, we're getting personal.
We're getting
relaxed. Lean back.
Get relaxed.
All right.
Yeah. I had my whole genome sequenced for fun. And I am a very healthy individual, and I have a very healthy family. And what happened was I got a call from a doctor saying, hey, you need to come and get your results from your genome sequencing. I'm like, why is a doctor giving me my results? Curious. Okay, I thought I will live through this. I will go to do this. Went to the doctor, and the doctor said to me, oh, I'm really sorry, you're going to get cancer. And I said, are you sure about that? And the doctor said to me, yes, look at these results. I'm like, give me the report. I looked at this, and I'm like, oh, I have an increased risk of getting cancer. Okay, got it.
What's in a word?
What's in a word? And then I'm like, do I believe this? Are the statistics good enough? Is the population level statistic on this variant good enough? The doctor could not answer this, had no idea. I said, okay, just give me the reports. Did some calling around, went home, read it, and I called the researcher who'd published the papers declaring that this increased risk of cancer. And I said, okay, tell me about the incidence and prevalence of this variant, because I'm looking, as far as I can tell, I've got the British variant of this variant in a gene, and there's variants in all different populations around the world, and I'm pretty sure that you didn't make a mistake because it's a British variant, and maybe it directs the accent, I don't know. But really, who has this variant who doesn't have cancer? Because as far as I can tell, in all these studies that you have published, you looked in families who have cancer.
Yeah.
And your statistics are pretty good in families who've had cancer. I said, how about families who don't have cancer? He said, you got me. Right? And this is why we need these population level studies, because maybe I will get cancer. But there's many different things beyond genetics. Maybe I have something protective. Maybe I don't. And nobody knows what the population level is for these kind of variants, because populations are only just at the point of being sequenced. So I think in 10 years' time, I'll have a different answer. But I'm going to take it one step further, because this is important to the patient choice, because I had this moment of like, I inherited this from somebody. Do I tell my parents? Do I tell my siblings? Do I tell my cousins? Do I tell my aunts and uncles? And that was an interesting perspective that I never thought about. What are they going to think when I call them? And I called, and my mother had like, and my father was like, oh, sure, I'll give you my blood.
Yeah.
So I went, and when I went, and lots of people in my family, we've discovered who's got it, who hasn't, who's been inherited. And now the researcher who published the papers is like, I love your family. Please, will you give us more samples? I've got all these triads.
I love it. Yeah, they didn't know who they were messing with when they called you.
No, but I bring it up because I hope I've answered your question about this, because I love it. Think about.
Yeah, no, thanks for sharing that. That was not only a neat story, but I love how it ends with the response from your parents were concern and love. I'll give you my blood. I'll give you that. And at the end of the day, that's what we do. That's what we all are doing. and that's why we do what we do. So we gotta make sure that we don't lose sight of that when we're talking about data and infrastructure and testing and clinical research, and because at the end of the day, how it's used and how people are impacted by its use is really, really important.
And I give my blood and my imaging studies, and I give it away to people. Yeah. I'm like, hey, you want this data?
Sure.
Have it.
Yeah.
Have it.
Yeah, I went back recently and revisited my. I play both camps, but this happened to be the 23andMe, and I went back and I reread some of the disclaimer as well as the consents in that, and they're powerful, right? If you really think about what's in those and what you're signing up to, and what they're foreshadowing, should you choose to have and reveal this data, not just reveal about yourself, but reveal about the economics in the health system and what you're exposing yourself to with that, et cetera. So data is becoming incredibly powerful. We have in Accenture, we have tech trends we do every year. Yeah. And in our tech trends, and this is universal across all industries, was one of our themes was around the need for data veracity, or simply truth in data. Right? And when we apply that within the context of health, it takes on a whole different level than it does in a consumer or a manufacturing industrial setting. Even just related to that story, tell me a little bit about how you think about when folks are approaching you with solutions, et cetera, or we could do this, or we could give you this insight. How do you think about that notion of data veracity or truth and what that means in terms of how you evaluate a solution or an offering or something?
So, J&J, I want to start with just giving you a perspective on how J&J thinks about the world, and then that will hopefully explain the way we think about deals and veracity and data. Okay. So I don't know whether anybody knows about our credo, the J&J credo. But this is basically our mission statement, which is written on the wall of every single J&J office when you walk in whatever language the local language is. And it's 75 years old, and it's a really interesting read, and it's something that we have to, when you enter J&J, you have to absorb. It becomes really useful for answering these kind of questions. Let me just tell you what it says. It's for 75 years old. I'm pretty impressed by what it says. The first one is, do the right thing, do something that's meaningful for the end user. So think about what that end outcome is and what you're trying to achieve. Don't do anything that's not going to make a difference. Second thing is make sure that you're doing the right thing for the employees, which is all about making sure that you're being fair to employees, safe work environments. Because actually, if you do that, then the employees are likely to not be disgruntled, but also likely to do number one because they're looked after themselves. The third thing is do the right thing for the community. And the community can be your suppliers, it can be the people around you, it can be your patient populations. It brings in, do the right thing for the community. Think about what you're doing and how you're impacting the world. Also, actually, remarkably for such an old document talks about the environment. And then the last thing it says, if you do everything else, you should do the right thing for the shareholders who've invested in the company. So that's the way it works. Then you asked me about veracity and data. If you go back to, are you doing the right thing for the patient? Are you making a difference? And so you need the data in order to measure whether your product is making a difference or not in that patient. And then when you go to paragraph 3, are you doing the right thing for the community? Let's make sure that we're looking after our community and we're doing the right thing for the patients. So data veracity fits into both of those pieces because you don't want bad quality data to encourage people to make healthcare decisions that are actually not going to be the right decisions for them. So that's the way I think about it. And so then when we look at deals, and believe me, we look at deals across the spectrum, across those areas, we always ask, if this works, is it going to make a difference? That is the first question we ask. The second question we ask is it scientifically feasible? Data veracity fits into that because what was the quality of the data? What is going to be the quality of the data? Is it going to be believable based on that? And the third one is really, what is the right next decision point? Because what you're trying to do is move things forward, and you don't want to waste anybody's time by doing the wrong experiments and doing the wrong partnerships. So I think I hope that answers your question, how we think about it. I think it's just in the DNA. Data veracity and making sure you're doing the right thing for the patient.
Love it. I love the time-tested value of your credo.
Well, it is time-tested.
Yeah.
That's the thing, is it's pretty hard.
That's when you know you got a good one, right?
Yeah.
That's fantastic.
And it's easy to remember.
Yeah.
It's easy to remember because, and this is for all of the startups in the audience, because I know that everybody thinks about culture and thinks about having your statements, and if it's not easy to remember, it's probably not right.
Yeah. Good pitch advice there, too. Okay, I'm going to bring us out. We kind of went down into data veracity. I'm going to bring us back out and talk a little bit about business models. I know you're a fan of network orchestration, or as we think about it within Accenture, platform-based business models that are built on ecosystems.
Yes.
Short answer, you can't do it all yourself, right?
Absolutely.
Is the way of thinking about it. Tell me a little bit about how you think about that as it relates to solving some of the challenges and the role of data within kind of health ecosystems.
So health ecosystems are local, meaning we have a local ecosystem here in Chicago, we have a different ecosystem in San Francisco, and the local ecosystem is driven by the doctors, the hospitals, the insurers sitting in that ecosystem. There's similarities between them, but they are still local. So you've got Kaiser, for example, is really big in one place. You've got Intermountain in another. You've got Stanford Healthcare, completely different model from each of those. I'm using a very Bay Area example.
Yeah, sure.
And then remember, we look globally, completely different ecosystems, still heavily self-pay in Asia Pacific, in Shanghai and China, but the prices are much more transparent. There, because you go into the doctors, you know how much it's going to cost.
Yeah.
Here, you go to the doctors, you get a bill a few weeks later and go, so and then if you go to some of the countries, like the country of my birth, which is the United Kingdom, then you have a nationalized healthcare system. So when you think about network orchestration, you have to think about, first of all, what is the ecosystem you're playing in, and then say, how are you going to make sure that platform connects the data from the different pieces? If you're talking in the UK, it's much easier. It's the NHS, the pieces fit together. They are the network orchestrator there. They are waking up to the digital world, and I think we have to watch out for that. I heard a company pitch just yesterday. They'd managed to get the NHS turned on, instant, 60 million people. And it's a data-related business model. And what they'd managed to do is test and learn in that system, which encouraged and fed the data back to the system, and now they've got that as really a very large payer suddenly on their model. Whereas here, you have to think about how are you going to connect the data from the payers, from the providers, from the other pharmaceutical companies, because honestly, we all want the right drug for the right patients. You have to connect that together, and this is where I actually think it's tougher in the US than it is in some of the other areas. So.
Interesting.
And you asked me that. I'm actually genuinely interested in your thoughts on that as well, because I think the concept of a network orchestrator, I mean, you use people like Amazon and Facebook and Google are the obvious ones. You look at them, they all have all the different pieces. They just choose to make money in a different way, but they are a network orchestrator, but they build it over time. And that's less local because it's consumer, whereas healthcare is more local because it's because it's delivery of healthcare.
Sure. No, I think it's an interesting construct and model to think about how, whether you're a J&J or you're one of the entrepreneurs in the audience, or you're a Best Buy, or your Amazon, or whatever. What is your intention, and what do you believe that you can, and what is the role that you can play in an ecosystem to deliver better care and improve that? And so I think we're starting to see that people are trying to discern what are the ecosystems that they plan to either create or participate in, and what their role is in those. For some, they may simply be a producer into that, like a third-party shop on top of Amazon.
Yeah.
I'm going to produce goods, I'm going to play in it, but I'm not going to worry about the ecosystem itself, and I'm not going to try to do more and put something in. So there are people who be great at science, and they'll produce great molecules and great medicines, but they won't go any further, right? But they'll be really, really good at perhaps a therapeutic area or a certain clinical platform to be able to bring those types of therapies to market. I think others are going to create those broader platforms. I think others, there's people in this room, I know some of the folks that participated in our pitch competition a couple of months ago here are working on creating ecosystems behind those localized structures to orchestrate care, right? That's a great example. So they're trying to be a platform provider that will orchestrate an ecosystem and manage the flow of information and data between them on behalf of a patient, right? So I think that we're going to see different people play different roles. And when I talked about the seams earlier, I think there are many people with designs on this industry from outside the industry that really think that they know what's best and how to meet a patient or a person in their home. Or when they think they're experts at lifestyle, in certain lifestyles that health plays a role in. So I think we're going to see that concept play out pretty dramatically, and I think the flow of information in that is going to be the lifeblood of those ecosystems, because by their nature, they need to exchange information, value, et cetera, in order to produce the outcome. So that's kind of some of how we think about it and how I'm looking at it, and frankly, what we're helping many companies do to both create those ecosystems or participate properly or intentionally in those.
No, I think that's interesting, and the example that you just gave of care coordination is something which I believe is a terrifically interesting trend in the US. And the business model is sometimes unclear for those, what I call the companies which are say, I'm just going to connect you to the journey of care. However, I'm just going to provide the journey of care, or patient, I'm just going to give you your appointment scheduling or something like that. However, I think when those types of companies start having real-time data feeds that via partnerships that they've made with a data provider, for example, with a cell phone or a watch, and they connect those and connect them with a lab, for example, for the genetic results, and you're having this constant real-time feed, it becomes the ways of that pathway versus the map of that pathway. And to me, that's an interesting one, and then there's going to be an interesting dynamic between who's going to profit, hopefully the patient. That's the end intent, but who's the sort of fight between, I'm a feeder of data versus an analyzer of data versus a presenter of data, and that's, I think, going to be a very interesting evolution that I'm fascinated to watch.
Fantastic. All right, I'm going to turn to a few of your questions. We've got about 20 minutes left, so I want to make sure that I'm incorporating some of what's on the minds of the folks out there, and then I'll close this with and bring it back to some of our thoughts and maybe some advice for folks in the room. So here's one that I think will be interesting, and it's got several votes, so we're going to go for it. Are traditional medical device companies recognizing the value of the data they produce and looking for ways to distribute the data to its stakeholders, patients, providers, payers, and researchers? Are they recognizing the value they produce and looking for ways to distribute it essentially to those that could benefit from it?
So I don't think I can speak on behalf of the entire medical device industry. So so the answer is,
all right, we'll call,
I don't know that.
We'll call AdvaMed to get a point of view on that.
Okay. However, my perspective.
Yeah,
however,
sure.
I do believe that all of the providers of medical devices are looking at the episode of care as the value creation versus just the device in itself.
Yeah.
So I think that these solutions that are going to need to be developed that include things like exercise, pre and post joint joint surgery, for example. That's very near and dear to J&J's heart. It's better value creation for the end user and the patient, and I think that that's some way where you have to look at the data that can be developed from a wearable, connected to an iPhone, connected over time to data streaming from a device. And I'm talking about this as an artificial hip or a knee, for example. And I bet the question was more about some of the pacemakers. I deliberately chose the different examples. The answer is, I think every medical device provider is looking at that and trying to figure out what does it mean.
Excellent. A perspective on that, I'm seeing many of our med device clients really start to think about what role they have in, as you said, in broader care provision, and actually using the insights they have to change care protocols. Absolutely. In many cases, and for the betterment, speed, effectiveness of treatment, et cetera. So I think they're using that capability. I think the real question is how well do they integrate into the clinical environment and make it easy for care providers to be able to operate and execute on that data, and do that so it's not one from J&J and one from the next guy, et cetera, right? Because that interoperability is really a key aspect of what I think the provider side of the community and others are looking at. I think the second part, and I think you addressed part of this question earlier, is about the patients and really keeping them in mind. If everybody's trapping the data and it's for the use of a provider and or a payer or a producer of goods, a manufacturer or a pharmaceutical, then we're doing it wrong. Because if it's not on behalf of driving it for the patient, then we aren't there. We talked a little bit about some of these kind of ecosystems. There's some interesting question out here. Do you think Google, Apple, and Amazon have the same principles for entering healthcare as J&J? If not, can they succeed? I wonder if their credo reads the same as yours, huh? Maybe it's another way of saying it.
Do no evil, right? Isn't that Google? Do no evil?
Used to be, yeah, used to be.
Used to be do no evil here.
Right.
So I have never worked at any of those large companies. I know a lot of people in those companies, and I think that back to the individual human level, I think I am a glass half full kind of person. I think that most individuals actually want to do the right thing for society as an individual. Then we see a lot of data scientists coming out of school and going into these large companies and then working on ad clicks or advertisement optimization. We then see them coming out and coming to work for large healthcare companies or in the startup and the biotech ecosystem because they want to take that expertise and know-how and apply it to something which fits with our human desire to do something meaningful or good for the world. I think many people have that. So I think that Apple, Google, Amazon are looking at this and seeing the healthcare as a large untapped market. And I think they're also seeing that they have expertise that can be applied against that market. I think via a series of different kinds of partnerships with startups and large companies, they're actually getting healthcare expertise. And for example, if you take a look at Google, there are several large partnerships between large healthcare companies and Google. Verb Surgical is one, the J&J example. There are other examples. Yeah. And I think, again, it's a network. They're really good at one thing. The healthcare companies are good at other things. The doctors are good at other things. And we just have to make sure that we're listening to the perspective of everybody. So people always normally ask me, oh, do you think there are threats? Do you think they're going to kill J&J? All those kind of questions. I think there's a place for everybody in this ecosystem. And I think that people develop and move forward together. But you have to have, that's back to your question about regulations, you have to have regulations.
Excellent. Thank you for that. I am going to, this is a little bit, not a spicy question, but it's, the way it's worded gets a little bit combative. How best do we combat the notion of owning the data? Owning the data in this, like, who owns the data?
I don't find that combative at all. I just don't find that.
Not from your perspective, just in the market in general.
Yeah, no, I understand. I personally think that the data coming from an individual is data about themselves. I think that companies will create unique and proprietary data sets, but I don't think anybody's going to own all the data. So that's my perspective, and as I back to the individual and the individual role in the data, I think over time individuals are going to be the steward of their own data, just the way they're going to be steward of their own finances. And I think they partner with large companies like a J&J to make sure the right clinical studies are done and make sure that the drug products, medical device products, have appropriate clinical data. So.
It's interesting. You know, I think about, you know, the example of Roche buying Flatiron as an example, right? It's a great concept of, I mean, literally it's owning the data. But I think that, but in that case, it's the construct and the intention, again, back to the intentionality, is far broader than owning that data or their ability to uniquely create and produce and curate that data. It's what are the set of services that can be derived, and at the end of the day, somebody else will invent the next Flatiron, et cetera. So how do you create an ecosystem that allows you to be able to harness those? And at points in time, I think people will want to own data, is my personal opinion, and they will, but it's a means, not an end, I think is the way
it's back
that
to
I would say.
what's the question you're trying to answer? And but there's certain data that people do own, like what is the quality control metric data on a device? What is the that's data that the provider of that device owns. Mm-hmm. They own that data. And then there's data that we're talking about, the human condition, that comes from the individuals. So yeah, people own pockets of data. I don't see that there's, people talk about, oh, there's going to be big data, this enormous big data lake. I'm like, different people own the data, and then there's a set of different people that control it. You have to look at who controls it, who owns it, who controls it. And most importantly, for what question you're asking, which pots of data do you need to connect? And if you do it like that, and you're saying, which bits do I need to wire together? I don't need to wire everything together. I need to so in the Roche Flatiron example, I think it's really interesting. If you look at Foundation plus Flatiron and plus Roche clinical studies, and you look at, I've actually got a map of this in my mind, all of the different pots of data, it's very deliberately connecting different pots of data. And I don't think they have to own it all. I think they need to connect it all and then deliver the right results from it.
Yeah, absolutely. I would agree. And I think this notion of interoperability and the ability to be able to do that in a way that others can consume, and it gets back to that other question of kind of and that was a med device specific, how are they going to untrap their data to do it? And I think the key is that at some point, you know, that there needs to be less proprietary and more interoperability in the technologies and the ability to transport. So that would be a view that we certainly have.
Yeah, I'm going to poke on one more thing, though.
Sure.
I'm going to go back to the example of the genetic variation I gave an example.
Yeah.
So do I own that genetic variation, or does my parent own it? Or does my parent's parent own it? I don't know. Or does my cousin own it?
Yeah.
My sister doesn't, I know that much.
Further insight. Well, there's a question that's kind of along those lines, because it goes with the notion of owning and patients, because you made an assertion that at the end of the day, patients own the data. So it's fantastic that there's a lot more data, but that's not just in healthcare, it's everywhere. How do we get patients to act? It's a good question. I liked it.
How do we get patients
to act?
Act on which particular piece?
I think the way I read it is, how do we get them to act to be either stewards of that data or to use that data in order to help us help them, maybe is a way I would think about it.
I'm going to answer that question in a roundabout fashion, deliberately. So first of all, I don't think we're going to be having this conversation in a few years' time. Because do you remember when we talked about digital banking? Do you ever use the word digital banking?
Never.
Never. Remember we talked about digital queries. Do you ever say that? Say so. Yeah. And just bringing that, I don't think we're going to be talking about this in a few years' time, because I think it's just going to be natural, and I think we're going to get used to it. So I think the question is more about what is the tipping point to turn it from us saying digital health to health. And then what caused that transition in those other industries? It was because it delivered something of value to that individual, to the consumer, back to your point. It's caused everybody to switch to that kind of model. I can't imagine going to a bank. Much more convenient to do digital banking. So
yeah,
that's my
I love
answer
it.
to the question.
Okay, interesting angle. I go to a place with this one about literacy. We are all struggling, within the healthcare environment, of just having people within our organizations to have the literacy with the data that they have today, to be able to understand it, to use it effectively, and to do something productive with it, and be responsible with it. I think that is out there in spades with patients. Think about your mother, father, little sister, maybe, whatever it is, right? And if as we proliferate, devices, right? I've got my Omada scale at home. I've got my, Misfit sitting here. I've got so much data coming at me. But if I don't understand what it means when my Peloton said that I burned 700 kilocalories and how that relates to what I did or didn't eat, and what's the difference between carbohydrates and proteins, and that's a lot to come at people. So when we talked about getting patients to act, I think we've got a big hurdle out there to help them understand how to act and be literate with their own health data, and importantly, simplify and help guide their decisions, so that we can bridge that gap. That would be one of the things that I'm concerned most about, getting patients to act.
But this comes back to, it takes a variety of different people, because you have the super smart MD, PhD types that are going to invent things, and then you have the teachers and designers who are going to make it accessible to the rest of us. And I never thought about design until maybe 15, 20 years ago, because I was thinking all about data and technical things, and now I'm like, designers, can you help me explain this to somebody that's going to understand?
Right, yeah. And how do we interpret that, not only in a communication, but a device or a form factor, or a simple consumption model, right? That makes sense. So I think that's a great insight on design here, because it's and by that I believe you're presuming that that's customer or patient-centric design.
Patient-centric design, be it in form factor or delivery of information. Actually, I've got a great story on that one, for example,
Bring it on.
As a patient who actually didn't understand it at all.
Okay.
I'll share this one with you. So in a prior version, before I had my genome sequenced, I did a genetic test. I do all these things, the genetic test. And I got the results. And I'm staring at these results saying, I do not understand these results. How can I, because it was, I can't remember, it was some particular place where a variant was being looked at, so maybe it was like GG and AG or something like that. And as far as I could tell, I had 2 copies of one of the alleles and little bits of a copy of the other allele. And I'm like, that doesn't make sense. I can't have 2 copies and a little bit. It's either 2, 0 or 1, 1, or 2, 0 the other way around. And I was staring at this, I do not understand. And my husband came along, same husband, And he looked
Still with us.
Still with us.
All right.
He came and he looked and he said, "Why are you frowning?" I'm like, "I do not understand this data. I'm a consumer. It's meant to be consumer." And he just started laughing at me. That's because you're trained as a scientist. It's like consumers can't understand the idea of nothing. I was like,
Love
I think they can, but it was this funny thing, and he just was cracking up. Because I was like, how can I have a big bar and a tiny bar?
Yeah.
That makes sense.
That's great. Yeah, right. And there's not a lot of, on a per population basis, there's not a lot of scientists out there, and there's a whole lot of consumers, right?
Yeah,
so that
mindset. You have to, yeah.
Absolutely. That's a great anecdote. Okay, we've only got a few minutes left, so I want to kind of bring it back to, and by the way, there's just tons of questions, so I wish we could be here for 3 hours. But I want to turn it back to some of our entrepreneurs that are in the room. And just maybe some last quick points on key considerations. And how, when they come in to talk to you or your peers kind of within the industry, what should they be thinking about, and how do they position this topic of data when they come see you?
I'm going to sound like a broken record. Come position it as, what problem are you solving? Then, if you know what problem you're solving, how is it relevant to the company you're talking to? Because largest healthcare company in the world, we don't do everything in healthcare. So make sure you're talking to the right company if you want to partner with them or have equity or do M&A, whatever you want. Make sure you're talking to the right company. So do a little background research. So what's the problem? How's it relevant to the person you're talking to? What are the key things you have to prove, and what data is required to do that? And then, what's the business model associated with that, which gets into a lot of the data-related business models that we were just talking about. But always just assume that the person on the other side is not going to be as knowledgeable as you are. So it's about, again, the consumer communications. So even if you're talking to the smartest MD, PhD, they probably don't know as much about what you're doing as you do. So make sure you digest it.
Love it. Perfect. Well, I want to give you just one last shot that's not a question or driven, maybe just for a comment. We've got about 1.5 minutes left. Anything that we didn't cover that you just think that would be a useful nugget, especially for the broader, we've got representation from some of your peers and others. What's the call to action, maybe leaving the room, for folks around this whole concept of the evolution of data and maybe where it's going? What should we be thinking about next? And we'll close it.
I'm going to ask the same question to you, that's a tough one. I would say don't get lost in the hype. AI, ML, all of those things, they're tools. Don't get lost in the hype, focus on the problems, and then take a really careful look at what's coming along technologically, what's going to be possible in the next few years from the technology perspective, and what will that enable you to do that wasn't possible before. So take that Cloudera example. It wasn't really needed earlier in the evolution. It's a point in these cycles of evolution. First of all, you need more cheaper technologies to develop data. Then you start using the algorithms, and you need the increase in compute power. And then you need the right algorithms and the right problems. And then you say, oh, I actually need more data, so you need new technologies to develop more data. You see where I'm going? It's just it's a cycle.
Absolutely.
How about
Fantastic.
Oh, yeah, you're
time's up. No, I think there's two things. I would say, as much as you have a focus, exercise your peripheral vision every day. Look at what's coming from the right and from the left on the space that you're trying to address, and that's in front of you, because that's what's gonna drive a lot of the change. And your awareness of those will enrich kind of the problem at hand. And I think that's probably the biggest thing. And I think thinking about what you could do with somebody else's help to achieve your mission, I think is the other part, which is kind of thematic to what we talked about. And don't think you have to get it all done yourself. I think that's the theme of where we're going, whether it relates to the data or whether it's the business model. So please join me in thanking Rowan Chapman for a very insightful dialogue. Thank you. Cut from the live stream, and we'll mill about a little bit here if you have any other thoughts or questions or want to share amongst yourselves. Thank you so much for joining us today.